A new era in cataract surgery has begun, with advent of this new technology, which is bound to reinforce some concepts and shatter some. We present our experience with Rescan 700 in cataract surgery, which is an operating microscope integrated real-time spectral domain OCT with a resolution of 5 microns. The area of interest can be brought to focus by changing cube position and size. In manual incisions, the microkeratome caused shadowing on the OCT. These incisions were triplanar as planned but caused epithelial disruption at the entry site. The femtosecond assisted incisions were precise, triplanar and caused less epithelial disturbance when compared to those created manually. It was interesting to see that the femtosecond assisted capsulotomy caused superficial cortical disturbance. Superficial cortex adhering to the anterior capsule can be seen in the OCT image to the right of your screen. On the contrary, the manual continuous curvilinear capsular axis caused minimal cortical disturbance. This can be seen as hyperreflective, folded structure, without superficial cortical matter, on the top of real-time OCT image to the right. Rescan 700 can help the trainee to assess depth of the trench in real time during phocoemulsification. It can be seen on the OCT that after trenching till 80 to 90% of the depth, one can easily crack the nucleus. The rescan can also differentiate between suspected posterior polar cataract and true posterior polar cataract. A true PPC will not have clear space between posterior capsule and lens. This case was a true PPC with the posterior epinuclear plate still attached to capsule at the end of nucleus management. The next case is of a suspected PPC. There was clear space between posterior capsule and the lens opacity, hence hydrodissectio was done normally. We also saw that the posterior capsule doesn't stick to the IOL after the end of surgery. The hyporeflective area between the lax capsule and the IOL can be appreciated on the real-time OCT. Subclinical DSMET's membrane detachments were appreciated after hydratio of corneal incisions in uneventful phocoemulsification. These subclinical DSMET's detachments should be followed up with anterior segment OCT for their progression post-operatively. Real-time OCT monitoring showed gaping of femtosecond assisted corneal incisions after end of phocoemulsification and IOL implantatio. This reinforces the fact that, whether the incisions are created with femtosecond laser or manually, they have to be hydrated to achieve adequate apposition. Intraoperative OCT gave us new insights into cataract surgery. This novel technology can be used both as research and teaching tool for ophthalmologists.